we've got so Erica's very kindly going to run the Menti session. So if hopefully people are familiar with Menti, but if you're not, if you get your camera phone and just point it at the QR code on the screen, it should take you into the session. If not, there is a code there on the left. So we'll just leave that there for a short period of time to allow people to kind of get into the session.
I can see you all logging on, so hopefully you're all finding your way around.
Yeah.
Has everyone managed to get in, Erica?
I can only see 2 people having clicked on the heart, so it would be worth double checking with colleagues that they can see the landing page. So you should see a blank screen if you're on your phone. Nigel and Catherine, are you both on?
I'm on. I've got a question as well. Maybe I've gone too far, sorry.
Same.
Go ahead. Let me just try to scroll the screen through. Can you see the objectives?
Yep.
Is everybody on the same page now? I think hopefully we're all there.
Great. So this is just really reiterating what Amit shared in the presentation earlier. So we're just asking people to kind of bear those objectives in mind as we run through these short questions. So if we can just move on to the next slide, Erica. So we just thought it'd be useful just to kind of find out where everyone is in the country. So if people are able to just kind of pin themselves on the map, that would be helpful.
That's the hard bit, I think.
Oh yeah, we did have somebody in the North Sea the other day, so I don't know whether they were either swimming or on a boat.
So we've got 3 people so far who I can see. 4. We're nearly there.
People clustering around the north of the country. Okay. So as we move through the session, if people are struggling to kind of get stuff onto the actual Menti session themselves, you just feel free to type stuff in the chat box. And we're also recording the session as well, so we'll be able to sort of capture everything. So the idea of the session, as I kind of mentioned in our sort of introduction to the Frailty work stream, is to begin to sort of capture some of the good practice that we know that's out there, but also to capture what you as participants in the collaborative are looking for, so we can shape what we do within the collaborative around your needs. So if we can move on to the first question, Erica, that'd be great. So the first question is just really to ask people what elements of your Frailty service are you most proud of, or if you've seen a really good Frailty service, what elements did you feel were really sort of stand out around that? And hopefully we should start seeing some of these appear on the screen. Yeah, I think this the interface between hospital and community. This was a sort of point you were making in the presentation, Amit. That's the kind of, it's really important into that interface, because frailty is it's a whole system issue. It's not just an issue for the hospital.
Yeah.
Yeah, and certainly I think in terms of just my own personal experience of visiting sites, as in my role as an e-system improvement manager, scaling up services that are already there. I've kind of been to a few organisations where the Frailty service was quite small, and I think certainly over the last few years, I don't think there's a site that I've been to where Frailty has come up as an issue where the organisation has said they've got plans or they would like to scale up the Frailty services.
Vince, I know some trusts are also doing really good work with direct access to their Frailty same-day emergency care units, so I guess that might be something else worth reflecting on as well.
Yeah, so if we move on to the next question. So I think part of the collaborative really is to try and help participants overcome some of the barriers to delivering not just improved Frailty services, but you know, we've got the other work streams. So you know, how can we, you know, what are the barriers to kind of delivering good board rounds, or some of those operational processes that Ben Owens was talking about. So it'd just be really interesting to hear people's thoughts on what they see are the barriers. Yeah, so workforce availability, and I think we know that from establishing this collaborative that we know that there are going to be a lot of cross-cutting themes, and that's why we felt that workforce was a really important work stream to include. So it'd be interesting to kind of see what drops out of that work stream, particularly in relation to Frailty services. And what we're hoping to do is, and again, this is about kind of looking at sort of what the needs are of the participants, is to look at probably setting up some joint sessions. So there's certainly workforce seems to be coming across as an issue here. So it may well be that we want to kind of do something jointly with the Frailty work stream. And kind of here maybe around sort of some of the challenges and potential solutions around specifically around the Frailty workforce. It'd be interesting to kind of see if there's an expansion on organisational culture. And I think we've got one final slide, Erica, I think.
We do. I think people have been proactively filling the slides in as we've been waiting.
Yeah, I think that last point there around systems, and as Amit mentioned in his presentation, this is, you know, Frailty is a system-wide issue. I don't know whether that sort of comment chimes with you, Amit, in terms of the kind of delays in assessments and so on and so forth.
Yes, so it's quite a common theme, I think. I don't know if Nigel and others have experienced that, but I think in a lot of places we do see this kind of theme that, you know, patients might stay in a so-called medically fit for discharge ward in an acute hospital for, I don't know, 20 days, 30 days, and during that period they get various complications of stay in the hospital, whether it is C. diff or MRSA or a P or a DVT or chest infection or respiration pneumonia or a deconditioning. And the theme is that yes, they will get assessment bed, but why are we waiting for that for 6 weeks, 3 weeks, 4 weeks? And it's just a lot of time wasted. And these are patients who actually have very, very limited time. We think older people have got a lot of time, but you know, think twice. Do they really?
I see you've got your hand up there, Nigel, if you're more than happy to come in.
Yeah, I think that there's something, one of the pieces of work we're doing at the moment is getting people to understand have a broader understanding of harm, because there's quite a bit of a narrow view we have around harm, and people tend to be conflating sort of long wait equals harm. So it's all very much focused at the moment around the sort of the elective program, and I'm trying to get people to not lose sight of some of the other aspects of harm that we cause. And there's quite a bit of a paternalistic attitude for all very admirable reasons, where we think we're doing the best thing for patients by, you know, wrapping them up in cotton wool when they come into the acute, and actually we're not doing them any favours, and we are causing harm by keeping them hostage in hospital, and really not looking to see how we can get them out much sooner, much quicker.
Yeah, I think that's a really, really important point. And I think Ben Owens often talks about risk, and I know he touched on it in his presentation. Yeah, it's kind of, you know, we do sometimes, we frequently see this on a lot of our site visits, is we see almost a sort of, like you say, wrapping people up in cotton wool, and in actual fact, by doing that, we are in effect doing the very thing to them what we're trying to avoid is actual harm. But also, and I think, you know, Ben makes a really good point there about it's not just one patient that's experienced a poor experience. It's, you know, those patients that are waiting to get into that bed, if we move people on. So it's good to see this last question's generated quite a lot of input. But what we will do is we'll be able to hopefully PDF all your feedback and be able to circulate this around. I think the plan is that we will share the feedback from all 4 breakout sessions across everyone who's participated today. So hopefully you'll be able to see what other people have been putting in the other work streams. Also, it allows us to be able to kind of go through and start to kind of look at some of the themes, and I think definitely workforce was a bit of a sort of standout theme, as well as there seemed to be some kind of risk coming up as well. So that would be really helpful in terms of being able to kind of look at how we shape the content of the collaborative going forward. So I think we've still got a bit of time left, so I don't know whether it's
10 minutes, Vince. Yeah.
Yeah, so I don't know whether it's as helpful to kind of open things up for a bit of a discussion now, because we can capture this on the recording as well as what's going into the chat box.
I guess the important thing for us from a program perspective is to get your thoughts on where the focus might add more value. I guess Frailty, very similarly to all the other 3 work streams, has, you know, such a broad reach, and there's plenty of things that we could focus on. So in order to make the program relevant and meaningful to you, but I guess perhaps more importantly also to your staff. So one of the things we're really keen is for the collaborative to reach people working on the wards. So what is it in particular that would chime with those members of staff, or where do you think the focus ought to be, perhaps?
I think there's two broad elements to this. One is, what else can we do to stop frail people being conveyed to the acute hospital in the first place? And I get quite distressed when I look at our A&E system and see you know, a bunch of people in their late 80s and well into their 90s being conveyed, and you just have heart sink moments, because there must be something better we can do collectively as a system that's different, rather than bundling them up in the back of an ambulance. So I think there's something about that upstream element, which has got to be a joined up system response to that. And then there's something at the back end around how do we ensure that we're only doing what we absolutely need to do for this older person in an acute bed, and we do it as quickly as we can, and then get them back out. And I had a recent case where an elderly woman had a fall, came into A&E. Luckily she didn't need suturing, but they glued her laceration together, was able to go home, but by this time it's 10 o'clock at night. Now you just know what I'm going to say. And she ended up staying that night, and I thought to myself, well, okay, she'll go home in the morning then. 3 days later, she was still in the acute bed, had got confused. So the team thought we better investigate the confusion, and I'm saying, get her back home and then see whether, and then I had an interesting conversation about harm. I said, we have caused her harm, we've caused her mental deterioration, because we have kept her here, and we really should have done a lot better at getting her back home with whatever wraparound we needed to do in the community. And there's so many examples like that.
Richard, you were nodding quite strongly.
Yeah, absolutely. It's the story that you see time and time again, and there's nothing I find more frustrating than somebody being kept in hospital because they're too confused to go home when hospital is the cause of their confusion. I liken it to not being allowed to take ice creams out of the sunshine because they keep melting, and you think, oh, you know, it's just so. And the trouble is, you feel as an individual, you feel like a broken record, don't you? You're just saying, oh, it's Jennifer banging on about discharging these poor people into unsafe situations again. And so you're absolutely right that it's about getting people to understand risk. I try not to use the term risk aversion, because it implies that the discharging people is the risky option and you're just too scared to take the risky option. So I prefer to talk about risk blindness. So people don't always recognise the degree of risk that we expose people to when we keep them in hospital. So I think that is I guess it's a focused area. For me, with this sort of frailty work, there's probably two main work streams. One is developing and improving specialist frailty assessment areas and processes. The second bit is how we manage frailty in an organisation as a whole, particularly when people aren't within one of those specialist areas, and making all areas fit for people with frailty. So it's probably worth having a bit of a think about where each organisation stands in terms of that specialist assessment bit and the other bit, and what we can do with that. There's inevitably going to be overlap with some of the other work streams. So for me, a huge amount of it is about how you deliver ward rounds and board rounds and that sort of thing. And again, the workforce and so forth. So I'm sure there'll be opportunities for us to kind of dip into some of the other work streams as well, rather than doing this in isolation, to get some of the learning. And the some of the sessions online are going to be, they don't overlap, do they? So there's still the opportunity to kind of get that experience. So yeah, I think that's it's a universal problem. It is one that if you can make a difference to, would make a huge difference, most importantly to the people that are exposed to the risk, but actually the hospital benefits as well, because you're not full of people that you're making sicker and sicker and taking up more and more resource.
Yeah, I think it's a really good point. I've heard Ben Owens talk about risk blindness as well, and I think there's a sort of a number of causes for that. I think sometimes it's caused by a lack of knowledge around what's out there in the community. I think very often within acute hospitals, we are, for want of a better word, blind to some of the services that are out there and the level of service that they can offer to people. And I think one of the other things that leads to kind of risk blindness is kind of our own blind anxiety about, if we let this person go from the hospital and something bad happens to them, then it's going to come back on me. And we're not really kind of seeing it from the patient perspective. And I think sometimes the thing is around kind of challenging our own anxieties around that.
Yes, you make a very valid point, Vince, because a lot of clinicians, whether it is doctors, nurses, therapists, or whoever else, will have that kind of anxiety, because if that happens, if the person dies, this person will be, if not supported by the organization, or even if supported by the organization, still goes through a difficult phase sometimes. And that can be very individual rather than taking the whole organizational risk. So we can see it from a clinical point of view, but I mean, we all have to make decisions, and some decisions will fall flat. Most of the times we get it right. But yes, there will always be a very small chance that things will backfire. And I think it's a collective thing. Then we, as bigger organizations, we need to ensure that we have those protective mechanisms and assurances for staff in place to make those decisions which they feel uncomfortable about.
A lot of it's down to cognitive biases. So in this case, it's the bias of salience. So it's a lot easier to imagine something dramatic and awful than something more mundane happening. So when you're sitting on an aircraft rumbling down the runway, it's quite easy to imagine smashing, your life coming to an end in a fiery inferno at the end of the runway. Whereas you don't necessarily think about possibly dying of cerebrovascular disease in a number of decades' time. And the same happens with that discharge question. So it's much easier to imagine the disastrous discharge rather than the person who then becomes a bit muddled, stays in a bit longer, and then whatever else happens from that, they're harder to picture. So I think getting people to recognise that that is a natural thing can potentially be something we can use to help with that risk management, that risk assessment sort of thing. So yeah, that's something that we could think about trying to introduce.
How important do you all feel shared governance and I guess sharing risk is in this conversation? Because I think we manage those conversations within our organizational boundaries. So my bit stops here, so therefore the other bit is now somebody else's responsibility. But I guess with frailty, then this is an operational manager's perspective. But frailty is one of those subject matters that actually doesn't start and stop at defined places. So actually that collaboration for me is so important. And I guess you can't have collaboration without sharing some of that risk and that governance. But what do you all think about that?
I'll jump in. I think it can be a really effective tool, that shared decision making. So we've got a care home MDT that runs remotely. So there's GPs, there's community nurses, there's me, there's social workers, and all the people that we discuss are by definition sort of complex, and yeah, we try to weigh up the information and come to shared decisions, and very often those are about things like not coming into hospital, that if unless there are problems that simply could not be managed outside a hospital. So that sort of thing works really well if everybody's willing. It's still very difficult when somebody says, I worry about, but what if this comes back to bite me? So you've got to make sure that you've got the governance structures in place that, evidence the decision making. I think the likelihood of there being any negative consequences of this sort of shared decision making are extremely low, probably lower than when you're just going off making decisions on your own. But again, it's perception is important. But yeah, cross-boundary working is, I think it's hugely beneficial in terms of trying to break some of those cycles of readmission and that sort of thing.
Yeah,
I think-
absolutely. So, I think the fear is there among some staff, but I think if you really look at the numbers, the chances of somebody being reported to the GMC, RMC, or the court, or the coroner for these things where there is shared decision making and collective responsibility is actually very, very low. But then it's hard to sometimes then tell the clinicians this, but we got to do that. I think it's time to move on to the main room, I think.